Good afternoon, everyone. Welcome to our first virtual Essential Tools for Parkinson's Disease. As you know, up until this time, these have been in person, but we're glad to have the opportunity now to transition to virtual so that we can be able to still communicate with you and share knowledge with you about mid-stage Parkinson's disease. I just wanted to let you know that for those of you who got the confirmation email, which I'm sure you all did if you registered, there was a way to ask questions of our presenters that we'll do at the end of each of their presentations. And you can send those questions via email to pcoeducation@ohsu.edu. Again, that's pcoeducation@ohsu.edu. If you have a YouTube account, you probably know that on the right-hand side, there is a chat function, and you can also send questions that way. Jen Carpenter, our great education coordinator, will be monitoring them and sharing them with me, and then I will share them with you. So we are so excited to have our program here for you. And let me just show you the first, well, there we go, sorry. The agenda for today, which we will stick pretty strictly to it, so I won't tarry too long here. And I wanted to definitely thank our supporters for this program. Particularly, we get an education grant from Parkinson's Foundation, and then we have our gold sponsors, Boston Scientific and Lundbeck, and then our silver sponsors, Abbott, AbbVie, Accorda, Amneal, and US World Meds, which is now Supernus. Please know that at the end of the program, we do have a couple of our program sponsors, AbbVie and Accorda, that will have their own breakout rooms if you wish to talk to them and ask questions. All right, well, if you all are ready, I think I am going to take a moment and just briefly introduce someone that you've probably seen before if you've been part of our program attendees, and that's Allison Lindauer, who's a nurse practitioner for the Layton Aging and Alzheimer Center, and has worked very closely with the Parkinson Center. And she's going to present to you today about memory and Parkinson's disease, facing changes and planning ahead.
Thanks, Lisa. Do you want to stop sharing so I can share my screen? Hi, everyone. Thank you so much for having me, Lisa, and the rest of the team. I'm really pleased to be here today. This is an important topic for me, and it just really interests me. I'm glad to be here. So thanks for the invitation. Just a quick note about us. I'm with the Layton Aging and Alzheimer's Disease Center, OHSU. We're one of 31 NIH-funded centers that focuses on aging and dementia research, and we're the only one in Oregon. So today I will talk briefly about, very briefly about what is dementia. We had this talk in the past, and I think the Parkinson Center has it on video for you. So if you need to know more about dementia, go ahead and ask that team. But after we do a quick overview of that, we're going to talk a little bit about the relationship between dementia and avoiding serious health events, and then preparing for the future. So essentially, Parkinson's in about 50% of people who have advanced Parkinson's disease, they develop dementia. Dementia is a condition that affects memory, thinking, and judgment. And there are lots of different types of dementia. So Parkinson's disease dementia is a type, Alzheimer's disease is a type, all under the big umbrella of dementia. In Parkinson's disease, when people develop dementia, it's usually in the later stages. And sometimes before the actual dementia, we see some mild cognitive changes. And it gets kind of confusing for people because for some of us as we get older, our memories just aren't as brisk as they used to be. And people tend to worry a lot about, well, am I getting dementia or is this just normal aging? So before I get too involved in other topics, I just want to take a quick minute and talk to you about how the Alzheimer's Association approaches this conundrum. So as we get older, or even when we don't, we all make a bad decision now and then, right? People who have dementia, their judgment is consistently poor. We all miss a monthly payment, but people with dementia can't even manage a budget, especially in the later stages. Sometimes in the earlier stages they can. We all forget what day it is and then remember later. People with more advanced dementia not only get their days mixed up, but get their seasons mixed up. So even though it may be 80 degrees outside and warm and sunny, a person with dementia may say, oh, we're in January, or we may be in winter. People with dementia oftentimes have difficulty with a conversation. They'll have trouble finding the right word, or they may repeat the same conversational piece over and over. And then lastly, we all lose things from time to time, but a more serious change is when you lose something and you can't retrace your steps. So for example, if I lose my keys, I think, okay, well, it was in my brown bag, so I'm gonna go back to my closet and look at my brown bag. People with concerning cognitive changes don't do that. They automatically go to something like, oh, somebody must have stolen my keys, or just, I don't know where they are. So that kind of gives you a little bit of an idea of what we're talking about as we move forward. I just want to comment again that not everyone with Parkinson's disease develops dementia. And also, it's important to know that if a person does develop dementia, whether it's Parkinson's or Alzheimer's or vascular, it's nobody's fault. I think all of us can think of people who are brilliant, they exercise daily, they eat a very healthy diet, and they still get dementia. It's something that our country is working on. The funding for dementia research is increasing substantially. And I'm hoping we'll have some more ideas, but right now we don't really know why some people develop it and some people don't. We do know, however, that it is possible to minimize some risk around dementia. And I'm going to talk about that for a minute and talk about it in the context of preventing serious illness. And I'm sorry, I'm moving kind of fast. I want to be mindful of the time. On the first slide is my email address. You're welcome to email me if you have questions. So we do know what the research does tell us about minimizing dementia risk is if we exercise 4 to 5 times a week for about 40 to 50 minutes, we can reduce our risk of developing dementia. I can't say it's absolute, but it does help. There's something about breaking a sweat, getting the body going that is protective. Also, socializing is very important. I think for many of us, unfortunately, during the COVID epidemic or pandemic, we found that being isolated just kind of is tough, right? And maybe there are days when you just don't feel quite as on top of your game because you don't have to take a shower, get dressed, go to work. There's all these social skills and cues that happens when we socialize. So even in this time, do try to reach out via video or phone call, engage with your friends and family. It's really important. Eat a healthy diet, you know that. And the other trick to minimize dementia is to avoid serious health events and hospitalization. And here's why. We know that when somebody has serious health event, such as a fracture, a fall, or an infection, it makes a person vulnerable to memory problems and delirium. Memory problems in this case, it can be just some clouding, just not really on top of their game, or it could be something more serious like delirium. Delirium is an acute condition. It happens suddenly, and what happens is people just are not as engaged, they're not as aware, they're confused, they don't pay attention very well. They may be somewhat agitated, or they may be very withdrawn and just not interacting with you. So people with Parkinson's disease, unfortunately, are at increased risk of developing delirium, whether or not they have dementia, and especially when they're hospitalized. So we know that one study found that 56% of the participants developed delirium compared to those 30% of those without Parkinson's disease. Unfortunately, delirium does increase your risk of developing dementia. So our focus today, and as we move forward, is focusing on how to avoid developing serious illness so you can kind of avoid that cascade of problems, but also how to shape the care that you want, and how you want to shape the care that you want so that you'll get what you need. So this is not a very good graph, but I think what's interesting is you'll see that the main reason people with Parkinson's disease go to the hospitals for elective surgery. And Dr. Dale is going to be talking more about hospitalization, so I'm not going to touch on that. I will talk for a minute on falls and fractures. The third reason people with Parkinson's are hospitalized is due to other infections. And then the fourth are status changes, mental status changes. And I bet you that those mental status changes are often related to infections and falls. So I'm not going to go too far into the mental status changes. So in a nutshell, if you want to protect your brain, don't fall, don't get sick, and be prepared. Well, that's easier said than done, right? That's kind of a tall order. And I'm not going to spend too much time on falls because I know many of you are experts at it. But just to review, falls occur, in my experience and what I've seen in my practice, is when there's a failure of balance, strength, or wisdom. Every 20 minutes, an older adult dies from a fall-related injury. Use your tools, use your walking sticks. We also know that visual and hearing trouble can contribute to falls. For those of you who have hearing troubles and you don't like your hearing aid, I like the Pocket Talker. All this does is amplify sound. It doesn't do all the tricky things that hearing aids do, but it's kind of big and it fits on your ear and it's hard to lose. I know all of you follow your physical therapist's orders, so I'm not going to go there. But then let's talk for a minute about wisdom. When in my practice, I see a wise person, I know that they are listening to their family members when their families say, please use your U-step walker, or please use these devices. And I know families wised up to the fact that it's important to listen to each other and to communicate. And then, of course, the simple stuff, right? In your home, remove the throw rugs, use handrails, that stuff. Or just as important, I guess we could say, is falls are accidents, right? Nobody falls on purpose. We're all at risk. And again, similar to dementia, nobody's really at fault here. This is a picture of me and my dog. As human beings, we have 2 legs, and our center of gravity is fairly high. She has 4 legs, her center of gravity is low, and she's smart enough to know that you don't strap 2 wooden things on your legs and run around in the snow. So kind of an example of how it all comes together. So we talked about elective surgery, we talked about falls and fractures. Let's talk about other infections. So it's very important to stay up to date on your vaccines. Yes, I'd like to be able to say that we can prevent all infections, but the infections listed here are top ones that are really important and that we need to protect you from. So shingles or herpes zoster, This is the picture of the shingles. I'm sure, unfortunately, many of you have had experience with them. These are very painful outbreak. And what happens is when we had chickenpox as a child, the virus lives on our nerve endings. As we get older, our immune systems get older too and are not as responsive to or work quite as effectively. So that virus gets to kind of come back with a vengeance. Shingles is extremely painful. And unfortunately, even after the rash goes away, oftentimes the pain sticks around forever. It can also, if it's on the face or around the eyes, it can be very dangerous. So I really urge you, if you haven't yet got your shingles vaccine, please do so. That's really critical. I've been doing this kind of work for 20 years, and I've seen people do really, really well. They get a bad case of shingles, and it just takes forever to get back to normal if they even do. So protect your brain, protect yourself. Similarly, get a flu shot. I know in this time of COVID, we're all much more aware of this, and I think that's great. And unfortunately, COVID has killed many, many, many people. The flu does too, not quite so many, about 30,000 across the United States every year. But do be protective and get your flu shot. Now, this one, you probably know it as TDP. This is typically for children, right? Just check it out with your primary care provider and make sure you've had it, not only to protect you from tetanus, but also if you're around any young children, pertussis is a big concern, also known as whooping cough. In adults, it's kind of an annoyance. It's a lingering cough that doesn't go away, but for babies, it can be deadly, similar to your measles, mumps, rubella. So that's your vaccine information. Protect your brain and eat a good diet. The Mediterranean diet has been proven to be helpful for protecting the brain over time. Still, however, illness will be in our future. We can't get away from it. We're human. Hospitalization is likely, and yes, we all die. So the next steps I'd like to talk to you about is preparing for the challenges ahead. And Dr. Dale in the next talk will also touch on this. But what I'd like to talk about briefly is advanced care planning. Advanced care planning is a process that supports us as we learn and talk about and share our personal values and life goals and preferences. So if you remember earlier, I said, it's likely that we'll end up in the hospital, and it's also possible for many people with Parkinson to develop delirium and confusion. When you're in that worst case scenario, you need somebody, a spouse, a kid, somebody that knows you well, to step up and make those decisions for you in ways that you want, that is under your control. So basic advanced care planning includes who would you want to make those decisions for you, and what kind of care do you want, and what is important to you. Now, sometimes we think of advanced care planning as a big, long, involved emotional conversation, which yes, it can be and often is, and that's appropriate. But know that sometimes advanced care planning just starts with naming somebody to make those decisions for you. Calling out a daughter, a son, a spouse, you're going to be my decision maker. Let's fill out a form to make that happen. Your advanced directive is in more detail. There are programs that help you talk about your goals of care, but for many people, they have a lot of clarity about that, which is really nice. I'll talk about the PULSE in a minute. And then, of course, end-of-life decision making. That's something you do want to talk with your family member about. But who is your best proxy? It really needs to be somebody you can trust and that can talk about your values, goals, and preferences. So it may not necessarily be the person closest to you. It may be somebody that you're very close to but have a lot of trust in. And you know that they'll follow your wishes and is willing to accept the role. There are two types of advanced directives. Actually, there's probably several, but I just want to talk about two right now. The first one is the advanced directive, and the second one is the physician's orders for life-sustaining treatment. I think they've changed that to portable orders for life-sustaining treatment. And this is important just so you understand the difference. An advanced directive is for anybody over 18. It is a legal document. It's not a guide for emergency personnel, and it's not an order for emergency personnel. So an advance directive isn't going to tell emergency personnel when they get to the scene what kind of care you want. It's more of an involved process. They don't need to have a healthcare provider's signature, but you do need to appoint a representative, a friend, a family member. And there's no registry. You keep your advance directive in your files, and we would hope that you would share it with us so we can put it in your chart. The PULS, the orders for life-sustaining treatment, are actually orders. Many of you have seen it, I'm sure. It's a bright pink form, and it's most at risk for people who are ill, or for people who are worried about developing dementia or delirium and want to make sure that their wishes are known while they can engage in that conversation. The PULS is a medical order for life-sustaining treatment. So these are the orders that medical personnel do look at in an emergent situation. It does need a health provider's signature. It doesn't identify a family member to make decisions for you. Your signature is recommended but not required. And then we submit all of the PULS to the Oregon PULS registry so that when when 911 is called, the paramedics know before they get to the house what they want, what you want, what your wishes are. That could include CPR, no CPR, limited treatment, advanced treatment, really basic questions that are very helpful and informative to you and your family. I started my conversation with you today about dementia, and I'd like to pull us back to that for just a minute. For many of the people I work with, they come to me with either moderate or advanced dementia, and they can't really engage in a conversation about what they want their advanced directives to be. Please don't let that get in the way of thinking about it and helping them come to some type of decision. Some people with dementia do have lucid moments, and that's a great time to try to get a sense of what their values are. But if you think about the person's life, you think about their life story, oftentimes you can come up with, yeah, no, my dad would never stand for being in the hospital for 2 weeks, and that will frame your conversation. We can help you, your healthcare providers can help you, and together you can arrive at the best judgment. I highly recommend this because families that have to make these really tough decisions in a healthcare crisis, when they know ahead of time that they've thought about it, they've talked it over, their stress level is lower and their grief, even after the event or the death, is more manageable. So take a couple minutes and think about how to protect both yourself and your family. Here's some ideas on this slide set of how you can start the conversation. Dr. Dale will also mention the 5 wishes. These are just ideas for you to work from. And my time is running out. So I think in the end, in summary, enjoy your life, protect yourself, plan ahead, and let me know if you have questions. At the Layton Center, we're always doing research studies with families that live with dementia. Love to hear your questions and love to hear from you if you're interested in any of our research. So thank you so much. It sounds like we're going to have some questions, and I'm going to stop sharing my screen. And maybe Lisa, you can help me out.
You bet. Thank you so much, Allison. That was really great and very helpful. We do have a question from Ellen on the YouTube chat about how much risk are outpatient procedures?
Yeah, that's a great question. How risky are outpatient procedures? Think about the degree of the procedure and and what's involved. So, what we know is the risk of delirium increases when there's use of general anesthesia. So, if it's an outpatient procedure that requires general anesthesia, that's a bit dicey. You want to have a really good conversation with your anesthesiologist to make sure they're doing everything they can to minimize the risk. If it's, on the other hand, a knee injection or a Botox injection, that's fine. It's the general anesthesia that we worry about.
Thank you. And I would also suggest, if you have any concerns about a procedure that you're going to be going into, to make sure that you check with your Parkinson's provider in advance of the procedure. So if they have any concerns, they can relay those to you. And I know that Dr. Dale in her presentation will also kind of cover just things to be cautious about.
That's very wise, yes.
So one of the other questions is, what are common over-the-counter medications that you might recommend avoiding to keep us healthy mentally as we age?
Great question. Thank you. I feel like you're a plant. So the medications I would avoid are medications that have the initials PM or the word SOM after them. These medications like Advil PM, Tylenol PM, Walsam, these are medications that are designed to help us go to sleep. Unfortunately, they use a type of medication that is in a class called anticholinergics, and they can make us, they can increase our risk of memory trouble as we get older, and we know that they also increase the risk of falls. So Advil, Tylenol, those drugs are fine. It's the PM and the SOM part that I worry about. Think of it this way. When we meet somebody with Alzheimer's disease, we give them a medicine called Aricept. The point of Aricept is to increase the choline in the brain so that the cells can communicate. These are anti-choline drugs, and they can be very hard on the brain. Please also be very careful with prescription medicines for sleep, such as Ambien or Sonata. I'm going to get in trouble here for mentioning brand names, but all of that whole class can increase the risk of developing memory trouble if they get more than 30 doses a year. So just really stay in close touch with your doctor and make informed decisions about that. Thank you. That's a great question. And it's a whole nother talk.
Thank you, Allison. So Sandy was wondering, is it okay to get a shingles vaccine during COVID-19, and is it available?
Yeah, that's a great question. Just call your main doctor and check it out. Again, I don't know because every person is different. If you have any risks for COVID-19, such as being over the age of 65, goodness, we're all at risk now, or other health conditions, it might be wise to wait. So do talk it over with your primary care provider, and even your Parkinson's doctor could probably give you some insight on that. It can have side effects and it can challenge your immune system. So even though I'm sitting here saying you must do it, do be careful.
So an interesting question that's a little broader, but would be good to have your take on it. And that's during COVID-19, when, we're recommending isolation and you might live alone, you might be a single person. How does one socialize?
Yeah, that's a tough one, isn't it? It's so hard on all. I keep hearing over and over and over how hard this is. And the fact that you're on today's meeting is a very good sign. It means that you have the skill set to be able to do video conferencing. And I think that's probably the safest way to engage with family. We know that being outside and being 6 feet away from somebody is a safe way to interact. And in fact, in our family, we interact with other families by having distance dinners. They come over and they stay far away from each other. It's a little weird, but it is so nice to see them and laugh together and spend some time together. It's tricky. I agree. I've also seen people, you've probably seen this too, driving around their neighborhoods in cars, like they'll drive up in front of a person's house and wave. I've seen one family drive up to a house. They stayed in the car, but they all sang happy birthday to the person in the house. It just forces us to be really, really careful. I saw a note that I do want to address, Lisa. Is Benadryl safe to use for sleep? Sorry, that's also one of the anticholinergics, and thanks, Ellen, for mentioning that. I forgot to note that. So I would avoid it. If you can, talk to your team about other options.
So I think in addition to, how to socialize, and you've given great suggestions, I'm going to have Jen share a link from a newsletter that went out from our center that did have information about virtual exercise classes. And Parkinson's Resources of Oregon has all kinds of virtual support groups. And
they're great. Yeah.
Yeah, absolutely. So there are possibilities out there, but it is challenging. And again, kudos for being here and educating yourselves and connecting in any way you can.
And while she pulls that up, Lisa, here's a crazy idea. Write a letter to a friend and put it in the mail. Remember when we used to do that? It's so much fun to get a letter in the mail, isn't it? Yeah,
it's true. It's true.
So yeah, do that. Especially for our people that are isolated in nursing homes. It's that isolation is really hard on them.
Mm-hmm. So Bob has a couple questions.
Oh, good. Okay.
One is, are there any significant changes to the content of the post, or is it just more of a name change? Mm-hmm. And can you speak to things such as CBD or THC tinctures to help with sleep?
Mm-hmm. Great, thank you. You're such an informed audience. It's so fun. Yes, the post has changed, and Lisa, maybe you can chime in on this. It used to be that we would ask the question about, do you want tube feedings? And they have, in my experience, they've taken that question off. So it's just basically, do you want CPR, and what level of care do you want if need be? So minimal care. So for example, maybe hospice care, limited interventions, maybe going to the hospital to get a quick antibiotics and go home, or full care, meaning intubation, CPR, the whole 9 yards. And again, it's your choice. We just need to know what you want. The CBD THC, I'm going to have to defer to somebody else on that. That's just not my area of expertise. I'm terribly sorry.
Well, I wonder if we might be able to punt that one to Dr. Dale. I know there is a resource online at the Parkinson Foundation, parkinson.org, where they've done a whole position paper on marijuana, CBD, and kind of addressed many of the issues and questions regarding it, particularly in relation to Parkinson's. So I would suggest kind of visiting parkinson.org for that information as well. And perhaps we can ask Dr. some more information during her.
Yeah, that's a great idea.
And to add to that, Jen's reminded me, we're actually going to have our next e-tool session with Dr. Nielsen. He's going to address that. So we'll be putting out information. It'll be a YouTube virtual essential tools session, as this one is. It'll be on October 29th, and we'll send out registration a month before.
Great idea. Great idea.
Yeah, I forgot we had that on already lined up. We have another question about, can you describe freezing, and does freezing often result in falling? And if you don't mind, I'll take that one.
I wish you would.
So freezing is a phenomena in Parkinson's disease where people can be either initiating, walking, be in the middle of a turn, going from one type of flooring to another, or through a doorway, and suddenly their feet freeze. It's almost like they're stuck in concrete and they can't pick them up. It definitely can result in falling. It is best treated by physical therapists who are knowledgeable in Parkinson's to kind of give you tips and tricks. helping manage it because it can occur suddenly. So there's definitely a difficult phenomena around that to be able to manage, and you should talk to your specialist in more detail to get some ideas. I know we had one question about what's the difference between anesthesia and sedation that you mentioned in.
You guys have such hard questions. And I think, I'm tempted to think about that and talk out loud about it, but I think in this situation, the safest bet is to talk to an anesthesiologist about the different options. I know they use sedation for certain procedures, but that's just not my skill set. I'm terribly sorry.
No, I think that's actually wise. Whenever you're going in for a procedure, there will be someone who will be handling the sedation or anesthesia. There's different terminology for it. You should ask questions of them. Often you'll hear terms such as general anesthesia, conscious sedation, nerve blocks, things like that. So there are different things, and different procedures require different modes of anesthesia or sedation. So it's a pretty broad topic, really.
Lisa, I have a quick question for you. In your essential tools programming, do you have a session on sleep and sleep safety? Great. I know we're getting a lot of questions about medications, and that's a tough one. So just want to make sure you have something.
Yeah, definitely. There is, in fact, Amy Hiller a while ago, a great talk on it. We've also had a series in our newsletter that's been available online for the different type of sleep issues. But again, it is something that can be pretty complex in Parkinson's disease.
Yeah,
and we have, or other as we age, other situations. So it's important really to work with your provider on that, because there are side effects on almost anything that you're going to take, even the over-counter things, and it's important to kind of know how that might interact either with Parkinson's medications or just the issues that go around Parkinson's. And so it does kind of take a little bit more micromanagement by your provider to really find what's going to be best for you.
Yeah. And I think the take-home message that I tell people, and this is not at all popular, but as we get older, our sleep is fragmented. So it's time, as we get older, don't expect 8 solid hours of sleep. It's not going to happen. But yes, absolutely. It's something that Parkinson's, it's especially challenging. So thanks for doing that.
Yeah. And if you're having trouble with sleep in Parkinson's, again, we're going to post a link to our video library, and on our website, you can find past newsletters that address it. But the main thing is to talk again to your specialist, because there's so many different types of sleep disturbance that can occur in Parkinson's. It's important to kind of sparse out what it is that's being dealt with and what's the best way to address it.
Absolutely.
We're down to a minute before our break. I'm just going to see if there's any more information on the chat or questions. I think we got most of them.
Terrific.
Hopefully we did. I want to thank Allison for her time and for the presentation. That was excellent. It really, I think, helps us all be able to be better prepared to stay safe and stay well and stay out of the hospital.
Yeah, and thank you so much for the invitation again. It's such a great group of people, and I'm honored.
Great. Well, I am going to share my screen while we have a 5-minute, I'm going to try to share my screen. 5-minute stretch break for everybody before our next presenter. And I'm sorry for the brief delay, but this, again, we're going to take 5 minutes for a stretch break. while we get set up for the next presenter. Welcome back, everyone. We're going to start our next session. If you're just now joining us, I hope that you take time later on, once we have this posted from recording our sessions, to see Dr. Lindauer's presentation that we just completed. Also, if you have time at the end of our program, we have a couple of our sponsors that are having breakouts that you can ask them questions and talk to them more directly. And that information and those links will be under the video on the YouTube channel where it says OHSU PCO, and then it'll you just click show more to get the see the links and click on them. All right, well, I'd like to introduce our next presenter, Dr. Marion Dale, who is one of our specialists at the OHSU Parkinson Center and the VA Parkinson Center. Marion, why don't you go ahead?
I'm just going to take a moment and share my slides. Let's see here. Okay. Is everyone hearing me okay? Yeah.
Yes, we are, Mary.
Okay, thank you. Just wanted to confirm before I launched in. All right, well, thanks for joining us this afternoon. I wanted to take a little bit of time to talk about tips and planning for in the event of hospitalizations that are helpful for Parkinson's disease. Of course, we'll touch a bit on the current situation briefly about COVID as well, since that's very much on everyone's minds these days. But a lot of this otherwise will be general information about pitfalls and pearls for when you're hospitalized, little tricks that we've learned from our patients and from each other through the years. And I should mention that at the end, there'll be time for questions. I think you have that on your agenda. I think we're doing that via chat box, and Lisa will help send those questions to me, and we'll answer toward the end. So in terms of what we're going to talk about today, it's of course important to have a plan in place for your Parkinson's care in the case you need to be admitted as an inpatient, either for elective or for an unexpected emergent procedure. So I'm going to talk about medication tips and other pitfalls to avoid, et cetera, during hospitalizations. And so these are the kind of breakdown of topics we'll go over today. First of all, before you're even in the hospital, pre-hospital planning, things to think about. And then we'll touch on medications, like I mentioned, both good ones and bad ones that should be in mind when you go, excuse me, when you're admitted. And then a brief mention of COVID-19 considerations. And then at the end, I'd love to take any questions or also any tips from all of you, if you may have had a particularly good experience during an inpatient hospitalization, something that went well, tips to share with the group, or conversely, if there were particular problems or pitfalls to avoid. So first, to talk about pre-hospital planning. We'll kind of start at the end for the beginning. So before you even get in the hospital, it's really helpful to think about the backside of that, what will happen in terms of discharge resources. And so this mainly focuses on the type of procedure you'll have if you think that rehabilitation may be helpful, or if the doctors and rehab team end up recommending rehabilitation at the end of the hospitalization. It's helpful to kind of have an idea in mind of, which types of facilities are covered by your insurance, which particular centers, and then are there particular outpatient rehab centers in your area that others have found helpful? Perhaps you could ask at your local Parkinson support group, this place was really good for me after I had my knee surgery, and they were, they kept Parkinson's in mind, et cetera. It's just good to it's a good idea to have a lay of the land in terms of what might be feasible. And a lot of this does relate to people's particular insurance plans. And then if you're going home, is there any equipment that you anticipate you might need from home? And so it's often the case that when you're in the hospital or you're leaving rehab, there are teams of people to help support you and recommend particular equipment. But it is very nice to perhaps, if you think there's one thing that might be helpful, such as shower bars, before, to go ahead and maybe get that process going before you even are admitted. Additional care partners at home. So would it be beneficial to ask an adult child or a close friend if they could help stay with you for a few days upon discharge? A lot of people are really happy and willing to do that. And so just to have some potential folks to call or a plan for additional help. And then home health agencies, if that's going to be the plan for you on discharge, which ones are local to you, which ones are accepted by your insurance, and which ones have people with Parkinson's had particular success using. And then again, there's a social work team and discharge coordinators to help all of this. But again, just having an idea of your options is always prudent ahead of time. And then I believe Dr. Lindauer mentioned this already, so I'll just touch on it briefly. It is, of course, important to always think about your preferences and wishes for care when you're in the hospital. In the event that something unexpected happens or your condition takes a turn for the worse, what procedures would you want done or would you not want done? And in terms of do not resuscitate, do not intubate orders, and various other things. I think if she mentioned this, I won't go into it at length, but the 5 wishes document is a very useful tool to help talk through different scenarios and issues. And the website is listed down there at the bottom, 5wishes.org. If you don't specify any wishes, the default kind of plan is that you'll be full code with your care team. So they'll do everything to you. So it's if you have other wishes, it's nice to make those known and clear ahead of time, including with your family, so that everyone's on the same page. And so that's the workbook that's useful for that, the 5 wishes. It can produce a legal advance directive in 42 states, including Washington and Oregon. And I think it is available in 29 languages. So it's a very good tool to get the conversation going. Also consider medical power of attorney. Doing that, you have more flexibility in terms of care decisions, or do both. So moving on to a discussion of medications. So I'll start with medications to avoid. So these are typically antipsychotics, particularly some of the older ones that we call more sort of traditional antipsychotics. So medicines, if you get agitated in the hospital, maybe recovering from a surgery, they might give you some of these, such as Haldol, very commonly used in the hospital, but happens to be particularly bad for slows you down in Parkinson's. And I listed some examples of medicines there that are in that class. And so it's just good to know that certain ones should be avoided, particular to Parkinson's. Certain medicines for nausea are also very commonly given. So that's the antiemetics I have listed there, like metoclopramide or Reglan, very commonly given on surgical services after surgery to kind of get the gut moving again or to help with nausea. And those have the same side effects of slowing down your movements and aggravating your Parkinson's symptoms. And that's because all these medicines modify dopamine, and so they can modify it in the wrong way for the Parkinson's. And I listed other examples there of medicines that are good to avoid: promethazine, chlorpromazine, and I put the brand names in the parentheses there. This is not an exhaustive list, but it's an example that we try to avoid. And then I did want to mention that there can be a temporary worsening of your symptoms, particularly tremor in Parkinson's, when steroids are used, like prednisone or other steroids, even inhalers that have steroid components. It doesn't mean that you should not take those at all, but it's just an FYI that tremor may temporarily worsen. If you need steroids for other reasons, then you need them. But that's just an FYI that it will temporarily worsen symptoms potentially, but then they should return to their baseline before the medication once you're off of it. So what medicines are okay to use in the case of agitation or confusion or nausea? So I listed some there. Quetiapine or Seroquel is commonly used for agitation, confusion postoperatively. There's another one called pimavanserin that is safe in Parkinson's, but that one is a specialty medicine. It may not be always available through the inpatient pharmacies. And so that one has a little asterisk by it in terms of availability is not always assured in an inpatient hospital setting. Lamotrigine is a good medicine for mood stabilization. For nausea, Zofran, or the other name for that is ondansetron, is fine. Sometimes we use extra carbidopa or domperidone for nausea, but these are harder to obtain in an inpatient setting. And so medication timing is very, very important issue in the hospital for Parkinson's patients. You want to, you may have been asked to hold your Parkinson's medications because they ask you to be NPO before a procedure. And NPO is Latin for nil per os, so it just means nothing through the mouth. And so ideally, the Parkinson's medicines should be resumed as soon as is safely possible after a procedure, once you're awake and able to take medication again. And then very commonly, there are issues where your Parkinson's medication schedule will likely not match the standard nursing medication administration times. So nurses give medicines on some type of schedule, and it does relate to their shifts and the other structural issues in the hospital, but it may not match what you normally take at home, which is the Parkinson's medicine schedule timing that has been designed specifically for you and your body, and how long the medicine lasts for you in terms of wearing off. And so there are some tricks for that. You can consider asking for specialized medication times, and that means that usually the doctors have to put the orders in a certain way, like they have to specify what times of the day you would get your medicine. Like I wrote here, 6 a.m., 10 a.m., 2 p.m., for example, rather than saying just 4 times a day or QID in the system. And so some of it just depends on the logistics of how the orders are entered in the system, and you could talk to your inpatient team about that. Consider asking for self-administration of your Parkinson's medications. So this may or may not be allowed depending on the situation and the protocol in the hospital. But there are some instances where the team and the nurses give the patients leeway to take their own Parkinson's medicine since they know what time usually works for them and how long it lasts, et cetera. And then if you have a specialty brand name Parkinson's medicine, such as the Inbrija inhaler or one of those other ones I had mentioned on the previous slide, you may ask during intake when you're doing initial interviews with the doctor and the nursing team, when they're initially getting your information, can you use your supply from home, especially if this is a medicine that's not available in the hospital pharmacy. There are some situations where the hospital says, no, you cannot use your home medicines at all. There can be liability reasons behind that, but I have also seen exceptions made, particularly in the case where, the pharmacy in the hospital, they don't have that medication, so you wouldn't get it otherwise. It's always important to have these conversations up front with your care team in the hospital to try to avoid any unexpected lapses, I guess, in your medication. Other medical issues, just briefly, things that can commonly come up in the hospital involve swallowing and confusion and blood pressure issues and other infections. I would say as a general rule, getting PT, so physical therapy, OT, occupational therapy, and speech therapy involved in your assessment and in your care as soon as possible is always very, very helpful to get all those specialists involved. If you have trouble swallowing at baseline before you're admitted, please let the team and the nurses know which textures you normally eat. Like, do you normally require soft foods? If you have hallucinations off and on, even before you're in the hospital, it's a part of your day-to-day life with your Parkinson's, please let the team know that, because they'll know to look out for any worsening of those. If you have blood pressure fluctuations, particularly drops in your blood pressure when you stand up, again, let the team know. These are just all common medical issues that can recur. If you suddenly feel more confused while you're in the hospital, there may be a new infection brewing, like a urinary tract infection, because maybe you have a catheter in that needs to be changed. These are just little things to look out for that can make a big difference. And then again, try to have some patience because, if you're in the hospital, you've probably been through a fair amount. There's stress on your body. If you've had a procedure, there's anesthesia that may be still hanging around in your system, a prolonged effect, and it can take a while to get back to baseline. The Parkinson's Foundation provides an excellent, what we call aware and care kit. So you don't have to memorize everything I just said about medications to avoid and pitfalls and things like that. You don't have to feel like you have to have it all in your head and keep it straight, perfectly, because you can take this little kit with you to the hospital. It lists great cards, it lists great information on cards about meds to avoid, information if you have deep brain stimulation for the team, information about what a duopa pump is, etc. It's just a fantastic resource and it's free. You can order it online. You can download a printable version. It's just something for if there are members of your team who are taking care of you who are less familiar with Parkinson's, it can be a great resource to help you communicate with them. Let's see here. I do want to take a moment though to just kind of give you, I think, maybe the physician nursing perspective on some of this too. So if you go to the Parkinson's Foundation website and you look at this aware and care kit, they talk a lot about advocating for yourself, which is very, very important. I think they say like call your outpatient doctor, let them know you're in the hospital right away and things like that. I think it's important to know that that the nurses in the hospital, like I said, they are under certain policy restrictions. And so it's going to be kind of a matter of working together within the bounds of what they can do and what you can do. So I would say I think the best way to approach this is to politely mention any concerns about your medicines, the timing of your medicines and things like that up front as soon as possible, kind of during that intake period, rather than waiting until, you're getting your meds late and you're frustrated and everyone's frustrated. Because if you mention it up front, it might give the team time to maybe potentially pursue whatever exemption they need to pursue to the policy, kind of get things organized to get you your meds adequately. So try to be, of course, polite and a little bit more upfront about it rather than waiting until the problems mount, which is what I just said there. Also, yeah, so this is kind of reiterating all these things I just said on this slide here. And then your inpatient attending, so the person who's taking care of you is legally ultimately responsible for your care while you're in the hospital. I think some people think that maybe if it's at the same hospital, their outpatient doctor can write orders while you're in the hospital. That's generally not done. So for organizational purposes, it's one doctor taking care of you. But that doesn't mean that the doctors can't and shouldn't be talking together. Hopefully they are, particularly in the case of any problems. But it is important to know that one person kind of has ultimate responsibility. And so for you, during that time period, it would be the inpatient attending or physician assigned to you. And that's just structurally how things work for organizational purposes. So moving on. So a brief note on COVID-19 and considerations for Parkinson's. I mean, I think the first thing that I'll say, a big disclaimer, is that we're still learning about this virus. Clearly, we don't understand this virus. No one does in terms of many things. It's a really evolving issue. But there's this potential for the nurses to be more overwhelmed during this time period or pulled in more directions or more short-staffed. And so if you're in the hospital, which we hope you're not, but if you're in the hospital during this time period, again, maybe self-administration of your medicines, if it's allowed, that could help out in a timely fashion. It might help ease their burden a little bit. It's just something to inquire about in terms of feasibility. And then urgent and emergent procedures are still important. So strokes aren't stopping just because of COVID, and urgent other infections aren't stopping. So we really, really don't want people to wait until the point where they're having severe other issues from other medical issues. So it's just a risk-weighing thing. You have to weigh your risk of waiting and worsening infection or stroke or whatever the issue may be versus, if you're someone with Parkinson's, you already have significant swallowing problems and you're at a higher risk of pneumonia. It is a certainly a higher risk of having COVID-19 complications. And then I've seen some people who are nervous about physical therapy, and at a certain point, PT is still really important to keep mobility going, even during this time of COVID-19. Otherwise, as you all know, everything can kind of spiral downhill if you're not moving with Parkinson's. So I have patients during this time period who are receiving home health with appropriate mask precautions, and they're making good progress with that and retaining their mobility. So again, that's a personal decision about the risk benefit of that, but movement and PT is still so very important for everyone with Parkinson's during this time period. Good, and I think we're running maybe a little ahead of schedule. I wanted to make sure to leave plenty of time for questions from you, and also I would love to hear particularly people's tips if they've had particularly good successes in the hospital or things that they have learned. I may not be able to answer everything as relates to various particular medical scenarios, but I think at this point we can open it up for any questions or discussion.
Thank you so much, Marianne. Again, another great presentation and very helpful in preparing everyone for what could be inevitable. Falls, infections, various things, surgeries, as Allison had pointed out, are all things that we end up in the hospital for, so it's best to be prepared. We have shared on the YouTube the link for the Aware and Care Kit, as well as the fact sheet information. And we do have a couple questions, and that is one from Hetty was, why not use medications up to surgery or liquid levodopa to prevent the poor post-surgery recovery? This is done in Europe for people with Parkinson's disease. And maybe, Marianne, you could address what instructions, we usually recommend for someone who's going into surgery.
Yeah, so ultimately the anesthesiologists are generally the ones in cooperation with the particular surgeon to decide how long medicine should be held before various procedures. Depends on whether they're GI procedures, so gastrointestinal procedures or not. That's a really fantastic question about liquid levodopa. That's a kind of a high level question and a very, very good point, well taken. It's often hard to find that type of preparation of levodopa in US hospitals. We can sometimes get sublingual levodopa, but that's still an issue. So under the tongue levodopa, but that's still an issue in terms of some anesthesiologists are still worried that a lot of that is, that's being swallowed and is still an issue for, it doesn't meet requirements for NPO status. So I don't have a great answer for why like liquid levodopa isn't generally available in the States. Supply wise, that would be a great question for a pharmacist. But I think that is very germane question in terms of how they do things in Europe. Lisa, did you have anything to add to that?
Yeah, I think one of the things that we've recommended that when they do talk to the anesthesiologist, and of course, if there are any questions by the anesthesiologist, to check in with us, but most, directions of NPO after midnight, all that, they do allow you to take critical medications with a small sip of water, such as cardiac meds and things like that. And often we have recommended that levodopa should be considered critical because it makes a difference in how loose you are in transferring and, on the table and everything else while undergoing surgery, and then to restart it as soon afterwards as possible. We do have a lot of new things coming up, like the inhalable Inbrija levodopa, and some actual under the tongue that's more where you don't just have to swallow your saliva because it dissolves as the Parcopa is, but a newer drug coming out that's more like a tape sort of thing. But again, these are new, they're not readily available, they tend to be expensive. And so in the future, that'll probably bode well. But again, as Marian said, it'll all be up finally to the anesthesiologist and what they think is best for you, and what the surgery is that you're undergoing.
Yeah, I agree. Those are great points. And I would also say the longer the surgery you're undergoing, the longer the anticipated surgery, all the more important to try to take levodopa beforehand as a critical medication, or to take your whatever your Parkinson's medicines, those be considered critical. I mean, there are certain surgeries that can last 10 hours, and that's a really long time during the day to go without your medication. And so for longer surgeries, very involved surgeries, that's a good point to bring up with the anesthesiologist, especially.
One of the other things I wanted to mention in the discharge planning period, which really for any medical team, when you come into the hospital, they immediately start planning for your discharge. And so you should have a social worker or nurse that's part of your discharge team, as well as whoever the attending physician is. But it's really important for the caregiver to communicate with them about their own health. If they feel like the individual is going to, by all measures of the medical team, they think they can go home because they have some supervision at home. But the caregiver is also perhaps older, may have back issues, may have other things that need to be taken into account in the care of the person with Parkinson's. That needs to be shared with the discharge team. And it may be beneficial to have that the person with Parkinson's go to a rehab facility for a time, when normally it might not be something that they would have been the first choice for discharge, but they have to take into account the caregiver's health as well. And that's often overlooked. So I would encourage you to advocate for yourselves in that respect. And one of our participants mentions that they wish they had pre-planned, especially researching what rehab facilities to work with their insurance, because it's really overwhelming to have to make that decision in a short period of time. And so I really like what Marian said, to do that ahead of time, to talk to your insurance, to find out maybe in your support groups, what ones are they felt, if they've undergone surgery and gone to rehab, what they felt is good in your location. So I know that Jane offered that she has actually created her own document that includes anesthesias, apparently that have worked for her, or maybe not, medics, opioids that do not work, comorbidities. A lot of this is information that they should be asking you when you go in for surgery, and hopefully are prepared, but that is a great way to do it. Have your own personal document that is geared towards you. We do have a hospitalization form that we can share. I don't think I have it easily accessible at the moment, but we can share it later, where you can personalize what your medications are, what your non-motor symptoms are, and it also has education for your medical team about what is concerning in Parkinson's. It's kind of a very short information, but can be the critical information that you could have if they're not quite getting the education from the wear and care kit. And you can have your doctor sign off on it as well.
Yeah. I agree with that. The anesthesiologist may be interviewing you at 6 a.m. or something. Maybe you're an 8 a.m. case, and so everyone is tired, and it's not, you have to come up with all this information about your medical conditions and good meds and bad meds for you. And it is nice to have it organized in written form and fairly succinct. Like, I like the idea of a page, because they're not going to have time simply to go through pages of records at that point in the process.
Mm-hmm. Yeah, I think, we've seen various experiences, both with our form, with the Aware and Care Kit. Sometimes it's welcomed and readily utilized by the hospital medical care team. Sometimes it's not. So again, I just think it's so important for you to share who your specialist is or their nurse's phone number to make sure that they can, having a doctor-to-doctor consult is invaluable. And even a recent situation, I had a patient who was in the hospital. The family alerted us that they might be getting medication that was not appropriate for someone with Parkinson's. I spoke with the attending who was very open to our recommendations. They were going to be giving the individual something that was not advised. And then also had them talk to one of our physicians. And things went well until they went to the rehab facility. And then I think they ignored our advice, but we didn't have that handoff where we could have it. But again, it was something where they were very open and they just need to kind of make that connection with medical, doctor to doctor. So they have that reinforcement and the doctor knows the individual best for collaborating. Marion, I'm going to throw one more question that was asked in an earlier session. It's a little broader. And I'll forewarn you, we are going to have a Dr. Nielsen's going to be presenting on it in October. But the question came up about CBD and THC for sleep, because Allison was warning that, a lot of the over-the-counter drugs that have PM on the end, use Benadryl, those sorts of things are not good for us as we age and mental health. And so she deferred on what that might be for in sleep. And I had recommended the Parkinson.org, position paper on it, but didn't know if you had any comments in your own experience.
Right. It is a broad topic. I think making sure if you're taking products like that they're more CBD than they are THC is important. So that ratio, making sure the THC component of it is fairly low is important. It's hard for me to put an exact number on that, though there's a naturopath that we work with frequently who has, studied various ratios and things like that. But we just don't want too high of a THC component and risk worsening, any kind of paranoia, hallucinations, or for some people, it really does lower their blood pressure and they have a lot of issues with lightheadedness. Beyond that, what really needs to happen, honestly, I think from a research perspective is that cannabinoid products need to be certified as sort of a lower schedule from the federal regulation standpoint, meaning that we'll be able to do more research with them. So, there are scheduled medications and these products are listed as like very restrictive in terms of what research can be done. I know the American Academy of Neurology has been advocating for some time for changing these policies on the sort of the DEA like federal level so that more research can be done. That is one limitation that we're up against in terms of clinical trials with these products, though certainly certain places are doing some of those. And so we do lack a lot of objective data that we would normally want to be able to properly counsel patients about specifics. I'm glad Dr. Nielsen will be talking about that in October. Hopefully I can leave it at that.
All right, thank you. I'm going to share on the YouTube chat the link to the Parkinson's Foundation website on use of marijuana in Parkinson's disease. It has several links to expert briefings and things like that as well, if you're interested. Well, great. Thank you so much, Marion, for your presentation. We got one more question. Are Parkinson's patients more at risk of developing neurological complications if they get COVID? That is a good question.
Most of the current like research I've seen coming out, and also in terms of sort of more informal conversations we have with European colleagues through webinars and things, through American Academy of Neurology, more and more there's suggestion that the neurological side effects of COVID are more due to not enough perfusion of blood to the brain, particularly related to small clots and things like that. Ischemia. We were worried initially that, you know, this virus could cause a lot of inflammation in the brain and that type of neurological disorder. We really don't know for certain, but there's been less evidence of that over time and more evidence of issues due to low blood pressure, low perfusion, small clots in the brain and things like that, or frank strokes related to it. I have not seen any study, nor do I think there is, or data about Parkinson's patients specifically with regard to COVID risk. Although I think it's common sense to say that if there's already trouble swallowing and risk of pneumonia, that would put you at an elevated risk, I think, of lung complications with COVID. But I think time will tell on this, and we're watching all the reports and the data closely. And some of the European studies, we're seeing those sooner than the ones in the States, just since the pandemic hit them earlier than here.
All right, thank you very much. So again, thanks everyone for joining us. I want to remind you that we do have the chat rooms and links to them where you can meet with David Hughes of Accorda and Michael Vitti of AbbVie at the bottom of your YouTube screen. Just if you haven't expanded it, just hit show more. We are going to be sending out a survey because we'd love to hear back from you about how this went. Since I know many other places have started with virtual events and we're kind of new to it. So appreciate any feedback you can give us, and that will come through Jen by email. And then we will be posting the recorded version of it so that you can see it. It'll be available on YouTube and probably within the not too distant future. Jen will also alert you to that. And you already have the slides that were shared in the confirmation email. So I'm gonna sign off now and allow you all to connect in if you so choose with our sponsor breakouts. And if you have any other things that come up or questions that you'd like us to have passed along to our speakers, then let us know and we'll do that. But again, thank you so much for joining us today, and stay safe out there.
Thank you, everyone.